Radiographic evaluation, anatomy, and classification of acetabulum fractures. This is from the OTA Resident Lecture Series, version 3. I'm Saqib Rehman, and I'm going to go through the slides prepared by the authors listed here. So the first thing I think you have to look at is just a basic understanding of how to orient yourself around the acetabulum and the sort of column concept, which is very simplified here in this drawing, where you have this inverted Y, two-column concept, and you can see in the middle there is your articular surface of the acetabulum. Okay, and we'll go through this quite a bit here. So Judet and Letournel were two French orthopedic surgeons, Robert Judet and Emile Letournel, and they have provided a lot of the foundation of understanding for acetabular operative management. So you're going to hear their names a lot, and we're going to look at the acetabulum the way they've taught us and also use their classification scheme. So Judet and Letournel showed that the columns, this anterior and posterior column, are connected to the SI joint by a thick area of bone above the greater sciatic notch, known as the sciatic buttress, and it's a term I'm going to come back to a few times. So that's where that inverted Y. So the anterior column, or the iliopubic column, extends from the anterior iliac crest to the symphysis pubis, and there's three segments: iliac, acetabular, and pubic segments. And then there's a posterior column, and don't worry, I'm going to show all this again and again ad nauseum in some pictures. It extends from the greater sciatic notch to the inferior ischium. Okay, and then you also have the anatomic roof of the acetabulum, which forms a keystone of that arch. All right, so here's some of our drawings, right? So and notice the the pelvis is oriented in such a way so you have this inverted Y. Okay, so you have the articular surface of the acetabulum oriented this way, kind of like an upside down horseshoe. Okay, and then you have the anterior column here and the posterior column here. So you kind of have this, sort of inverted Y. Okay, so this is obviously here shown from the outer aspect or outer table, and here this is shown from the inner aspect of the pelvis, or medial aspect. All right, anterior column, posterior column. Now, if you were to take a sawbone model or some type of plastic bone model and pick it up and look at it, this is something how that might look. So again, the acetabulum is oriented such that the articular surface is in this sort of horseshoe, inverted horseshoe. Posterior column here, anterior column here, and this is shown from multiple different views. Okay, posterior column, anterior column, and then in the back of the pelvis you have the posterior column here, greater sciatic notch up here. Okay, and then the blue part is the ischiopubic ramus, kind of uniting the inferior ends of the columns. All right, this is a 3D anatomy viewed from above that we'll sort of come back to a few times also. So let's go over some important vascular anatomy. So one of the important things you need to know about is the obturator artery. In normal anatomy, it originates from the internal iliac artery. It's has a small caliber anastomosis between it and the external iliac system, and you'll see this as a retropubic anastomosis. So that pubic branch of the obturator artery commonly has this anastomosis shown in that green arrow with a branch of the inferior epigastric. So if you're doing surgery, for instance, and you're working on the retropubic bone, you may encounter these anastomosis. Now, in an abnormal situation, the obturator artery potentially can originate from the inferior epigastric artery or the external iliac, and that can be particularly large. So here you can have a very large anastomosis that is found on the retropubic surface, and this is the so-called corona mortis, or the crown of death. So whereas you may frequently encounter anastomosis here, when it's big, that's when it can really get you in trouble. And remember, it's always some type of anastomosis between the obturator and a portion of the external iliac or inferior epigastric vessel. Okay? Good test question. Other vascular anatomy of note, the ascending branch of the medial femoral circumflex, okay, shown very nicely here in these injection dye specimens. It is the main blood supply to the femoral head, and it lies deep to the quadratus, obturator internus, piriformis, and superficial to the obturator externus muscles. So, practically speaking, this is something that can be damaged with dislocation of the femoral head, and then when you're doing surgical approaches, this is a little bit of a hard image to understand if you're not oriented, but think about if you're doing a posterior approach to the hip, right? And when you do a total hip, you sort of just take everything right off the bone. Well, when you're doing an acetabulum, you don't do that. That is, when you're trying to fix an acetabulum and not do an arthroplasty. You have to leave a tag, because if you go right down to bone, you can devascularize the medial femoral circumflex artery. So you leave a tag, you actually cut the tendons, and importantly, you also don't take the quadratus femoris off of the femur, because again, you can end up devascularizing and damaging the medial femoral circumflex artery. So we leave the quadratus femoris alone. So here you can see here the quadratus femoris has been left on the femur. The obturator internus and the gemelli muscles are tagged, and then the piriformis is tagged as well. Okay. The superior gluteal artery comes through the greater sciatic notch. It can be damaged by aggressive superior or lateral retraction of the abductor muscles during the Coker-Langenbeck exposure. The sciatic nerve, unfortunately, is the most common traumatic and iatrogenic nerve injury. It's very important when you're doing surgery, for instance, that if you're doing a posterior approach, you keep the hip flexed. You keep the hip, I should write this down, you keep the hip, should be extended. And the knee flexed. Okay, so that relaxes the nerve, right? So very important to remember this. I'm sorry if you can't read it, but hip extended, knee flexed. That relaxes the sciatic nerve. So when you're doing a posterior approach, you position it that way, and you should hopefully avoid iatrogenic nerve injury. Obviously, you have to know where the nerve is. There is some degree of variability, but for the most part, it's fairly well described. There's a lot of surgery that's been done in the back of the hip, so it's a familiar location, but certainly if you mishandle the nerve, you can end up with a foot drop, and of course, sometimes the patient already comes with it. Now, the superior gluteal nerve also comes through the greater sciatic notch. So lots of stuff coming through the greater sciatic notch. So really be aware of it, understand where your retractors are in relation to the greater sciatic notch, because there are a host of things that you can damage retracting around there. The inferior gluteal nerve innervates the superior third of the gluteus maximus, and located halfway between the greater trochanter and the posterior superior iliac spine. When you do a Coker-Langenbeck approach and you split the gluteus maximus muscle, you have to be very careful not to split it proximal or superior to the point where the nerve comes in. Otherwise, you can damage the nerve and denervate the gluteus maximus. Alright, so I'm going to actually pause there. We will pick up the rest of this in the next portion of this lecture. Thank you.